afternoon, everyone. I welcome all of you in the 100th session of e-NISCHIT, the national initiative to strengthen the collaboration between HIV and TB through e-learning platform. So first I introduce myself. I'm Dr. Jyoti from Share India, a technical consultant, and we have a team who is providing a technical support behind the curtain from ECHO and Share India. Uh, we have Dr. Ananya Prabhu. She'll be moderating the session. And today we have the eminent expert, Dr. Praveen Chawla, who is the senior ENT surgeon at Jaipur Golden Hospital, Rohini, Delhi. And he is expert in the vertigo. He is a vertigo specialist. And today we have a case of atypical presentation of extrapulmonary TB in parotid gland, parotid cyst. The case is being brought up by Dr. Prapa Ganguly. She is the medical officer at the ART Center, SSKM, West Bengal. So now I would like Dr. Prapa to present the case.
Good afternoon, everyone. I feel delighted and glad to be able to present another interesting case at Share It Initiate platform. This is a very different kind of case of extrapulmonary tuberculosis who is co-infected with HIV. She is a 19-year-old female. She came to us in September 2022 after being detected HIV positive. So all of us at the ART center, we were very surprised to see such a young person with HIV infection and coming to us. So we started taking a detailed history as we take for all other pre-ART patients. And we came to know that this patient has been suffering for last 10 years with the infection of infection of parotid gland and recurrent fever and cough and tonsillitis. So she had been suffering for a long time and taking advice and treatment at different places. And at last, one surgery was planned, and incidentally, it was found out that she's HIV positive. Both her parents were HIV negative. After ART registration, we waited for a few investigations as we could see that there was a consistent swelling at the left parotid, near the left parotid gland. So we initiated ART on 12th October. After initiation of ART, we started going back, and in retrospect, we started checking all the investigations done before. The previous FNAC did not show any report suggestive of TB. So we did the report again, and then we found out that this consistent parotid swelling and abscess is due to tuberculosis. So the TB ATT, we confirmed it on 26th October, and TB treatment was started on the same day. The patient had no past history of TB, and she first, when she came, she just had a soft painless swelling below the left ear with ear infection, but it did not look like a cold abscess, or she never gave any history of previous tuberculosis or any of forest positive infection right then, the first day. But then they gave us a detailed history of recurrent cold, salivary gland enlargement, left ear infection, and on and off fever for last 10 years. As I told you before, that she had been treated multiple times with antibiotics, but the conditions did not improve. In September 2022, the swelling increased considerably, causing deafness in left ear, and a surgery was planned for the parotid cyst at a private hospital. Incidentally, she was found HIV positive, and immediately she was sent to us at SSKM. After knowing that the parents were seronegative, we started taking history of the patient regarding the source of infection. So the patient, presently she's studying in a college, but she and her parents, both I mean all three of them gave us very clarified, and it was a very evident, it was very evident from their history that she had no other possible source of infection of HIV, but she only had a history of blood transfusion 10 years back during an episode of dengue. And that time also she was admitted and she had a blood transfusion had to be given. So that this was also another concern why I chose this case to present in this platform, that a patient who has come, a young patient who has come to us and incidentally detected to be HIV positive, most probably due to blood transfusion, and she is now infected with another deadly disease, and a typical presentation of tuberculosis. And so that also made me worry a little, that we are doing lot of improvement and progressive, we are taking lots of progressive steps in HIV and TB in both the sectors, but the patients who need recurrent blood transfusions, like thalassemia patients, or the patients due to any trauma or due to dengue or any reason where the blood transfusion is urgent and necessary, we are not able to reduce the risk of blood transfusion induced HIV to 0%. The patient, after giving the history, the patient came and we were working up with the patient, and then she came with a swelling below the left ear with discharge. So that was detected and treated outside as acute otitis media. She had dysphagia and she had oral candidiasis as well, and severe weakness and cervical lymphadenopathy. There, the USG neck showed the parotid cyst. Her chest X-ray and CB nat sputum was found to be normal. FNAC from the swelling showed benign cyst lesion. The CECT neck showed multiple thin-walled cysts in bilateral gland. The largest was 28 into 16 millimeter at the inferior part of the left parotid gland. So the patient suspected to have a typical presentation of TB. Repeated FNSC was also done in October 2022, and that cytomorphological feature also showed suggestive of granulomatous lymphadenitis. CB9 was non-detectable. Then the ATT started on 26th October and it was completed on 12th April 2023. Immediately after ART was started and TB treatment started, the swelling slowly disappeared and patient clinically and immunologically improved. So that showed us that a very different kind of presentation of a parotid abscess, which is due to tuberculosis, can be treated and a patient can have a great quality of life once it's been diagnosed earlier and treated properly. At present, her viral load is not below detectable line, and she is asymptomatic, continuing her studies, and she even completed her TPT. Thank you very much for this opportunity.
Thank Dr. Prapa to bringing out such interesting case. Dr. Ananya has joined with us now, so she will brief the case.
First of all, I would like to extend my greetings to all the medical officers, all the ART staff that have joined us graciously. And I would like to welcome our consultant, our Dr. Praveen Chawla. Thank you so much, sir, for giving us this opportunity to hear from you. We are really thankful. So I will just summarize the case. This is a case of a 19-year-old female, and she presented to us with a soft painless, presented to the ART center with a soft painless swelling below left ear with ear infection, and she had history of recurrent cold, salivary gland enlargement, her left ear infection for last 10 years. She was treated with antibiotics, did not improve until September 22, and the swelling increased, causing deafness in the left ear, and a surgery was planned for the parotid cyst at the private hospital. So it was during the PAC that she was found to be HIV positive, and ART registration is 29 September 2022, and she was referred to SSKM. She was registered on registered on 29th September, as I said, and the ART was started on 12th December 2022. So to 12th October, sorry. So the patient is a 19-year-old female, and she had with seronegative parents. So that is what is very interesting to point to note. And but she has history of blood transfusion during dengue 10 years back. She came with a, we will not suspect in a 19-year-old unmarried female anything of like this sort. So this history becomes very important. History of blood transfusion during dengue 10 years back. She came with swelling below left ear with discharge, dysphagia, severe weakness, and cervical lymphadenopathy. So she came with swelling. Her chest X-ray and CBNAT was found to be normal. FNAC from the swelling showed benign cyst lesion. CCT next showed multiple thin wall cysts in bilateral gland, largest in inferior part of the left parotid gland, and bilateral multiple cervical lymphadenopathy. So it was patient was suspected to be a typical presentation of TB, and repeat FNAC was done, which was showed cytomorphological features suggested of granulomatous lymphadenitis, and this is one giveaway for TB because we usually start our TB treatments on this granulomatous and lymphadenitis if it is collaborating well with the history. Then CBNAT was not done. ATT was started on 26th October 2022 and was completed on 12th March 2023. So patient improved clinically, immunologically, but persistent neck swelling disappeared completely. At present, her viral load is not detectable. She's asymptomatic and continuing on TPT. So what is important investigation wise in this patient is that her CD4 counts has been around 117, then in April 2023 it was 216, and viral load has been not detectable, so which is a good point. And there's no CBNAT was not done, so there's no CBNAT of the FNSC done. So, in case any other investigation, Dr. Prapa, if you want to add on, please tell us about the case.
Yes, uh, as you correctly said that the CBNAT was not done immediately, but it was done later. But because when I reported this case to e-NISCHIT, it was not done. The report did not come by that time. But later on, the sputum was done for CBNAT was done for sputum, and that was not detectable. And tuberculosis was it was initially for a long time, for 10 years tuberculosis was not thought of, and tuberculosis it was not started. She was not started on ATD, but initially it was thought empirically to start. Clinically, it was thought that we should start ATD, and we discussed with our chest department, and the nodal officer also agreed that yes, we should try ATD, and ATD anti-tubercular drug did wonder, and is completely fine now. She's continuing her college. The only sad part was she received blood transfusion some 10 years back for dengue, and that seemed to be the only cause for transmission of HIV. So it is very sad that since I think last 15, 20 years, we have been working with HIV and TB, and still we can see so many transfusion related HIV transmission, and which eventually risk them towards other deadly diseases like TB. Thank you very much.
Thank you so much for sharing this case and raising such an important concern about so many years have passed for us in getting our infection control practices in check. And still, if we are seeing cases HIV being spread through blood transfusion, it is indeed very sad. So thank you for the case presentation. I think it's time we can move to diuretic now, and I invite our expert for today, Dr. Praveen Chawla, sir. So kindly share your presentation with us.
No, good afternoon, the surgeon from Jaipur, Delhi. And we just had a case presentation by Dr. Prapa and Dr. Ananya regarding a young girl who developed tuberculosis of parotid gland, and she was HIV positive as well. As we all know, that tuberculosis is one of the opportunistic infections, and uh, and is more common and more severe in those patients who are immunocompromised. And HIV is one of those conditions in which the patient is immunocompromised. So we were discussing that the tuberculosis is an opportunistic infection, and that is more common and more severe in immunocompromised patients. And HIV, the patient becomes immunocompromised. So tuberculosis is more common. It is believed that tuberculosis is 25 to 30 times more common in patients with HIV than in normal individuals. Coming to extrapulmonary tuberculosis. Why a patient should develop extrapulmonary tuberculosis? This mostly correlates with stage 4 of the disease or an advanced phase of the disease. And together, HIV and tuberculosis, they have a worse prognosis than tuberculosis alone. In cases of extrapulmonary tuberculosis, which are more common in HIV, these are the sites where HIV is where tuberculosis is more common, like central nervous system in meninges, lymphatics in scapula, of the neck, as was decided in the 16th century in the lymphatics, followed by pleura, followed by disseminated tuberculosis, then bones, joints, and genitourinary. The extrapulmonary tuberculosis, the most frequent site is 42% in lymphatics, 18% in pleura, 12% for bones and joints, 6% genitourinary, 6% for meninges, 5% for peritoneum, and 11% other sites. So the lymph nodes are the commonest sites of extrapulmonary tuberculosis, and for both otherwise normal and HIV infected individuals. Involvement of meninges is more common in young children than in other age groups. But incidence of tuberculosis in the remainder of the extrapulmonary sites increases with age. As we have discussed, among the lymph nodes also, the commonest site for extrapulmonary tuberculosis in HIV patients is again cervical and supraclavicular, that is scrofula, followed by axillary, followed by abdominal lymph node involvement. If there are 100 patients who develop extrapulmonary tuberculosis in HIV, patients who develop tuberculosis in HIV, 61% patients have only in lungs, that is pulmonary tuberculosis, followed by 39% who develop the extrapulmonary tuberculosis. Yes. Out of them, 19% have got extrapulmonary alone, and 19% have got extrapulmonary as well as pulmonary. Now, it is believed that the immune system of HIV patients cannot respond as strongly to a tubercular infection, so they are not able to contain the tubercular bacilli within the lungs. It spreads to the bloodstream. The TB infection, which should remain in the lungs, but in case of HIV patients, it gains access to the bloodstream and spreads through the body. In HIV patients, the dissemination may be by bloodstream and can also be through lymphatics. Lower CD4 count correlates more with spread to extrapulmonary sites. Similarly, lower lymphocyte count and lower gamma interferon count also leads to spread to extrapulmonary sites. Besides that, HIV can also activate any dormant or inactive tuberculosis or a latent tuberculosis to become active. So that is also an important factor to consider. Now we are coming to the parotid gland. When we talk about a benign disease of the parotid gland, the commonest that comes to our ENT surgeon's mind is pleomorphic adenoma. And when we are discussing the inflammatory diseases, they include tuberculosis, actinomycosis, and sarcoidosis. If we talk about development of parotid gland by HIV, the commonest is development of lymphoepithelial cysts, which is the commonest lesion of parotid and submandibular salivary gland, followed by intraparotid lymphadenopathy, followed by parotitis, then diffuse infiltrative lymphocytosis syndrome, and certain neoplasms such as adenoid cystic carcinoma and Kaposi sarcoma. In this case, when we have to distinguish this case, we are considering two important things. One is lymphoepithelial cysts, and second is extrapulmonary tuberculosis. Now, extrapulmonary tuberculosis here may be either the involvement of the parotid gland or the involvement of parotid lymph nodes. So we are concentrating on these two differential diagnoses here. This is a case of HIV who has developed a parotid swelling, and this is one of the lymphoepithelial cysts. The lymphoepithelial cysts, they are mostly bilateral. The clinical feature would include fever, unilateral and sometimes bilateral parotid swelling, myalgia, and most important, they will have xerostomia, the dryness of mouth. Confirmation is by FNAC and by radiology. FNAC. FNAC will show intranodal cysts lined with epithelial cells, and epithelial inclusions of ductal origin is also seen. There will be presence of proteinaceous background with mixed populations of lymphocytes, histiocytes, plasma cells, and metaplastic squamous cells. The immunohistochemical detection of HIV-1p24 antigen is diagnostic of HIV-associated lymphoepithelial cyst. Ultrasound, so pardon my spelling mistakes here. There will be numerous anechoic regions without diagnostic enhancement with anechoic cysts. MRI will show homogeneously hyperintense on T1 weighted images, and there will be a rim enhancement. This is one of the slides showing a typical lymphoepithelial cyst. Then you can see the SNS material with lymphocytes and cystic macrophages. This is the MRI showing a cyst in the parotid gland, and this is besides parotid, there's involvement of the submedullary gland as well, and there is the rim enhancement here. The treatment for the lymphoepithelial cyst which have been caused by HIV, that will be antiretroviral therapy. They have good prognosis, especially in children. Repeat aspirations may be required, sclerotherapy may be required, radiation therapy rarely required, and surgery seldom. They respond very well to the treatment. Now, extrapulmonary tuberculosis in parotid gland is really rare and is taken for neoplasm and sometimes unnecessary surgery. As we were listening to this case also, the patient was posted for surgery for lymphoepithelial cysts. Sometimes a hard appearing parotid gland may be mistaken for pleomorphic adenoma, and surgery may be done. And so these patients present as non-tender, firm, diffuse enlargement of parotid, mostly unilateral. They can have ipsilateral tubercular lymphadenopathy also in the posterior triangle. And the most important factor, they don't have any xerostomia. It means there's no SNS involvement in these cases. This is one picture showing the photograph of a patient having parotid tuberculosis. The ultrasound guided FNAC in these patients will show granulomatous necrotizing lesions. There will be epithelioid granuloma, lymphohistocytic clusters will be there, with presence of AFP and Ziel-Nielsen stain. The ultrasound will show diffusely enlarged hypoechoic gland with or without cavities. This is one of the features in parotid lymphadenopathy. But there can be two types. One is parenchymal tuberculosis and other is periparotid tuberculosis, which may be even periparotid or which may be involvement of the parotid lymph node. In that case, they may appear like hypoechoic nodule in periphery with hyperechoic parotid gland with enhancing periglandular lymph nodes. The MRI will be hypointense T1 and hyperintense lesion on T2 with homogeneous contrast enhancements. This is a picture of MRI showing parotid tuberculosis. Another one. So treatment will be medical management with 6 months ATT, as we had seen that the 6 months ATT was instituted in the patient starting from 22nd of October 2022 to 22nd April 22. So 6 months ATT with initial 4 drugs and further 2 drugs with concomitant moxifloxacin. Concomitant retroviral therapy is also required, and it was, I think, also given to this young girl. Surgery is seldom required in the confirmed patients. Of course, when surgery is required and we get the biopsy material, that is even more diagnostic and more pathognomic of the disease than FNAC alone. Coming to parotid lymph nodes, Parotid lymph nodes is part of the lymph node involvement, as we call it in scrofula. That is the involvement of cervical lymph nodes, or previously called King's Evil. When in around 16th century, the Europeans believed that the disease would be cured by the touch of monarchy, so they used to call it King's Evil. It is part of disseminated tuberculosis. Can be unilateral. Bilateral swellings can also be present sometimes over the parotids. Again, there is no xerostomia, as the main acidic component is not involved. Delayed treatment can lead to abscess formation. That is important. And the abscess formation can lead to resistance to conventional tubercular therapy, and then MRD will be required. Presence of lymphadenopathy in the other regions is also there. This is a picture of where a patient has developed abscess, tubercular abscess. This is only a picture. It may not be related to HIV also. And this is the MRI showing development of abscess in this patient. Now, diagnosis of extrapulmonary tuberculosis in HIV positive patients. The new guidelines, which state that for lymphatic in the region, the diagnosis will be by in pleura, it will be aspirations and chest X-rays. For disseminated tuberculosis, chest X-rays and blood cultures, and for tubercular meningitis by lumbar puncture. So the diagnosis of parotid tubercular lymphadenopathy is by ultrasound, as we had discussed it earlier also. They will show a hyperechoic parotid gland with hypoechoic nodules located in the peripheral zones. FNAC will show epithelioid granuloma with or without necrosis, with giant cells and high AFP load on cell staining. And the treatment will be same for tuberculosis elsewhere in nodes, along with antiretroviral therapy. This is one of the slides showing tuberculosis in lymph node. So the take-home messages: extrapulmonary tuberculosis is a common feature in HIV. And out of them, 38% of patients they have extrapulmonary tuberculosis in HIV patients. The rest, 62%, have only pulmonary tuberculosis. Parotid lymph nodes may be involved in disseminated lymph node involvement in tuberculosis, but very rare. And parotid gland TB is extremely rare form of extrapulmonary tuberculosis in HIV, but should be kept in mind. Radiological tests such as ultrasound, MRI, and CECT may aid in diagnosis, but it is FNAC what really clinches and concludes the final diagnosis. ATT, along with retrovirals, they form the backbone of the treatment, and surgery is seldom required in these cases. Thank you.
Thank you, sir. Thank you for such an excellent presentation. Thank you, sir, for sharing your presentation and giving us such beautiful insights about how to suspect the parotid infection in an HIV. And as you talked about how TB and extrapulmonary TB with HIV becomes even more gruesome to treat and even diagnose at times. So we are going to discuss the pre-test and post-test questions.
So the first question was, which is the most common site of the extrapulmonary TB? एक्स्ट्रापल्मोनरी टीबी में सबसे ज्यादा कॉमन साइट कौन सी होती है? ऑप्शंस है lymph nodes, meninges, peritonia, genitourinary. And the correct answer for this question is option A, lymph nodes. Question 2 is, which of the following diagnostic tests is not advised for diagnosing EPTB in parotid gland? A, US guided FNAC, option B, USG, option C, MRI, option D, X-ray. So the correct answer is X-ray. X-ray is not advisable for diagnosing EPTB in parotid gland. So these were the two questions related to our case today, and I am sure that the participants had got the answer from the didactic itself. So over to you.
I would like to ask our case presenter Prabhu that if you have any queries still or you want to discuss with our sir, we can. And also from a perspective, if a ART medical officer is sitting, what expectation you have to know about a ENT case? Prabhu, if your queries are solved, anything you want to say?
Good afternoon. Thank you, sir, for this knowledge and this great presentation. We came to know about a lot of things. One thing I would like to ask is, the patient was suffering with parotid swelling for last 10 years. And when she came to us, she had problems of dysphagia and weakness and lymphadenopathy. But it was not a typical cold abscess. So, do we see this kind of features in non-HIV, non-immunocompromised general population also? Or how to suspect? I mean, I was very curious and surprised to see this much of delay in diagnosis of tuberculosis in her. Maybe nobody suspected HIV, and but TB should have been suspected before itself, and she was suffering for a long time. So that's my question, that how to go about with the patient who comes with a parotid swelling or normal ear infection or pharyngitis or tonsillitis. Uh, how to go about and think that this can be otherwise.
I would say that I would like to blame those clinicians who did not suspect tuberculosis in parotid gland, because tuberculosis, though very common in our country, is, I would say, really very common in our country, but extrapulmonary tuberculosis involving parotid gland is not so common. Again, extrapulmonary tuberculosis involving parotid lymph nodes is also not that common as in supraclavicular region or in jugular digastric or submandibular regions or in posterior triangle or occipital triangle. So to suspect tuberculosis even in a non-HIV patient, that too in parotid or parotid lymph node, doesn't come to our mind so easily. So I would really say that it was a close call. It was really because of some other reasons that it could be diagnosed. Otherwise, yes, but FNAC in these cases, FNAC is required in, even if you are going to diagnose a simple lymphoepithelial cyst of parotid or pleomorphic adenoma of parotid or any other lesion of parotid, we have to go in for FNAC, and FNAC could have concluded the diagnosis either in favor of lymphoepithelial cyst or tuberculosis.
Thank you, sir.
So in our case scenarios, sometimes we see that we start the patient on ART and then these swellings appear and these occult infections, they flare up because of something called iris immune reconstitution. So it's very difficult to predict that time or gauge that time whether we are dealing with something new or whether we're dealing with failure, because the swellings increase when the patient's immune competence is increased and he's able to manifest the symptoms. So, so that in HIV it becomes a little unpredictable how the path would be. So, I wanted to ask you, sitting at ART as a medical officer who's sitting there, so any red flag signs or anything you would like to say that should be like keeping in mind when they're treating, when they want to rule out ENT pathology and want to refer? Well, what should be in their mind that something you can add on?
Actually, when we are talking about a patient who's now detected to have HIV, for that patient we should have a strong suspicion of tuberculosis in any part of the body, pulmonary and otherwise. And in those patients, not only tuberculosis, we should be suspicious of other things also, like Kaposi sarcoma, pseudomonas infections, and even other fungal infections, candidiasis, aspergillosis. There are a number of other things. So for those patients, we should be on watch out for opportunistic infections and neoplasms in any part of the body.
Yes, I understand. So, but even after treatment, sometimes symptoms don't go away so easily, na? So, symptoms and swellings.
Yes, this is definitely a possibility. I don't know about the rest of the part, but in Delhi, we had seen that during the time of COVID, since most of the centers, even those who were catering to ART and those who were catering to DOTS, and they had to be involved for COVID duties. So there was a surge in HIV infections and in tuberculosis involving, you name any part of the body. We were seeing it. My wife is an ophthalmologist. There were rise in number of patients who had tuberculosis in involving eyes, ears, lymph nodes, tonsils, meninges, any part, salivary glands. There was rise in that period.
Okay, sir.
Okay, I thank you, sir, for the excellent presentation. I our participants from the ART Center definitely benefited with this directive, this session today. I thank you so much. Uh, I thank Dr. Prapa to bringing out such interesting case, and I request all our participants to send us the cases for the discussions in future also. And we have a YouTube channel. The recordings of the sessions are available on the YouTube. So you may go anytime and visit the YouTube channel and refer those cases for the references. So I thank all our participants. I thank Dr. Ananya, who has moderated the session so beautifully. I thank my team from EPO and Share India, who has provided the technical support. Thank you very much.